Tumor markers are biochemical substances produced by tumor cells or the host response. They can be detected in blood, body fluids, or tissue specimens. Most are not specific for malignancy and can be elevated in benign conditions. They are used for screening, diagnosis, prognosis, and monitoring treatment response. No single perfect tumor marker exists. All have limitations in sensitivity and specificity. Tumor markers are classified by their biochemical nature. Oncofetal antigens include Alpha-Fetoprotein and Carcinoembryonic Antigen. Glycoproteins include cancer antigen 125, cancer antigen 19.9, and cancer antigen 15.3. Enzymes and isoenzymes include prostate-specific antigen and neuron-specific inolase. Hormones include human chorionic gonadotropin, calcitonin, and adrenocorticotropic hormone. Receptors include estrogen receptor, progesterone receptor, and human epidermal growth factor receptor 2. Genetic markers include mutations, microsatellite instability, and circulating tumor DNA. Ideal tumor marker characteristics include high sensitivity for early detection of malignancy. High specificity with minimal false positives in benign conditions is essential. Correlation with tumor burden or stage of disease is important. A short half-life allows accurate monitoring of treatment response. Easy measurement with reliable, reproducible assays is necessary. Cost-effectiveness enables widespread clinical use. Clinical applications of tumor markers are diverse. Screening involves population-based detection in asymptomatic individuals. Diagnosis is aided when markers are combined with other clinical findings. Prognosis, prediction estimates disease course and overall survival. Monitoring assesses treatment response and detects recurrence early. Targeted therapy identification selects patients for specific biological treatments. Surgical guidance helps determine the extent of resection needed. Prostate-specific antigen is a glycoprotein produced by prostate epithelial cells. It is elevated in prostate cancer, benign prostatic hyperplasia, and prostatitis. Screening use is controversial and requires shared decision-making. The free-to-total prostate-specific antigen ratio improves specificity for cancer. Prostate-specific antigen velocity and density provide additional diagnostic information. It is used for monitoring recurrence after prostatectomy or radiation therapy. Carcinoembryonic antigen is an oncofetal glycoprotein normally produced during fetal development. It is elevated in colorectal, gastric, pancreatic, lung, and breast cancers. It is also elevated in smokers, inflammatory bowel disease, and liver cirrhosis. Its primary use is monitoring colorectal cancer treatment response. It is not recommended for screening asymptomatic individuals. Rising levels post-treatment strongly suggest disease recurrence. Alpha-Fetoprotein is the major fetal plasma protein produced by yolk sac and fetal liver. It is elevated in hepatocellular carcinoma and germ cell tumors. It is also elevated in pregnancy, liver regeneration, and chronic hepatitis. It is used for hepatocellular carcinoma screening in high-risk patients with cirrhosis. It is combined with human chorionic gonadotropin in testicular cancer management. Serial monitoring detects recurrence after tumor resection. Cancer antigen 125 is a glycoprotein expressed by coalomic epithelium derivatives. It is the primary marker for epithelial ovarian cancer. It is elevated in endometriosis, pelvic inflammatory disease, and pregnancy. It is not recommended for ovarian cancer screening in the general population. It is used for monitoring treatment response and detecting recurrence. It may be combined with transvaginal ultrasound in high-risk women. Human chorionic gonadotropin is a glycoprotein hormone normally produced by placental syncytiotrophoblasts. It is elevated in gestational trophoblastic disease and germ cell tumors. The beta subunit is measured to avoid cross-reactivity with luteinizing hormone. It is combined with alpha-fetoprotein for testicular cancer classification. Serial monitoring is essential for managing trophoblastic neoplasms. It is a very sensitive marker for residual or recurrent disease. Cancer antigen 19.9 is a carbohydrate antigen related to the Lewis blood group system. It is elevated in pancreatic ductal adenocarcinoma and cholangiocarcinoma. It is also elevated in pancreatitis, biliary obstruction, and other gastrointestinal malignancies. It is not sensitive or specific enough for pancreatic cancer screening. It is used for monitoring treatment response in known pancreatic cancer. It may aid in differentiating pancreatic cancer from chronic pancreatitis. Estrogen and progesterone receptors are nuclear hormone receptors in breast cancer tissue. Positive receptor status indicates hormone-dependent tumor growth. This predicts response to endocrine therapy like tamoxifen or aromatase inhibitors. Standard testing is performed on all newly diagnosed breast cancer specimens. Negative receptors suggest the need for alternative treatment strategies. Receptor status is an important prognostic factor for breast cancer outcomes. Human epidermal growth factor receptor 2 is a transmembrane tyrosine kinase receptor gene. It is amplified in some cancers, particularly breast cancer. Overexpression occurs in 15 to 20% of invasive breast cancers. It was historically associated with more aggressive tumor behavior. It predicts response to targeted therapies like trastuzumab and pertuzumab. Testing is done by immunohistochemistry or fluorescence in situ hybridization. Circulating tumor DNA refers to fragments of tumor-derived DNA in blood plasma. It represents genetic and epigenetic alterations of tumor cells. It allows non-invasive liquid biopsy for mutation detection. It is used for identifying targetable mutations and monitoring treatment resistance. It has an emerging role in early detection and minimal residual disease assessment. Technical challenges include low concentration and need for sensitive detection methods. Tumor markers have important limitations to recognize. Low specificity means many markers are elevated in benign conditions. Low sensitivity means markers may be normal in early-stage malignancies. Heterogeneity means tumor cells may not uniformly produce markers. The hook effect means very high concentrations can cause falsely low results. Assay variability means different methods yield different reference ranges. Interpretation challenges mean clinical correlation is always necessary. Proper interpretation follows specific guidelines. Always interpret markers in clinical context with imaging and pathology. A single elevated value is less significant than a rising trend over time. Know the half-life of markers for proper monitoring intervals. Consider benign conditions that can cause marker elevation. Use appropriate age, gender, and population-specific reference ranges. Combine multiple markers when appropriate for specific cancer types. Emerging markers and technologies are advancing the field. Exosomes are tumor-derived vesicles carrying proteins and nucleic acids. MicroRNAs are small non-coding RNAs with regulatory functions. Metabolomics studies tumor-specific metabolic profiles. Proteomics examines large-scale protein expression patterns. Autoantibodies represent the immune response against tumor antigens. Multi-omics integration combines genomic, transcriptomic, and proteomic data. Practical clinical scenarios demonstrate marker application. Rising Carcinoembryonic Antigen prompts colonoscopy for recurrence evaluation. Elevated alpha-fetoprotein with a liver mass suggests hepatocellular carcinoma. Cancer antigen. 125 monitors ovarian cancer, chemotherapy response. Prostate-Specific Antigen velocity calculation helps assess prostate cancer suspicion. Human epidermal growth factor receptor 2. Testing selects breast cancer therapy. Circulating tumor DNA detects epidermal growth factor receptor mutations in lung cancer. Thank you for watching. Don't forget to like, share, and subscribe. See you in the next one.